We begin this segment with the second debate. The topic of debate is what is the best management for low pole stones, retrograde intrarenal surgery, or percutaneous nephronal lithotomy. For the debate, we have two eminent speakers from the Urological Society of India and the Sri Lankan Association of Urological Surgeons. To conduct the debate, let me invite the chairpersons for the debate. Two of our legends in Sri Lankan urology, Dr. Anur Vijayawardena and Professor Neville D. Pereira. Over to you, sirs.
Good afternoon, all. It is my pleasure to introduce our first speaker for the first debate after lunch. He is Professor Anil Shesthra from Nepal. Professor Anil Shesthra is Associate Professor of Urology and Consultant Neurosurgeon and Kidney Transplant Surgeon in National Academy of Medical Sciences in Burr and B&B Hospital in Lajpur. And Dr. Anil Shesthra is actually conducted an excellent workshop 2 days ago at RCD Surgical Hospital as the beginning of our SLAUS sessions. Over to Professor Shesthra.
Thank you. Can I have my slides? Very good afternoon, respected chairpersons and dear delegates. I am extremely overwhelmed to be a part of this wonderful meeting in beautiful city of Colombo, and I take this opportunity to thank the organizing committee of SLAUS and especially my friend Dr. Kalana for having me here. So before we start, I take a moment to remember our very dear friend, Dr. Lakshman Prabhu, whom we lost this morning, and he will always remain in our heart. I bring greetings from Nepal and Nepal Association of Urological Surgeons. When we talk about stone surgery, it doesn't matter where the location of the stone is. The most important two factors that we have to keep in mind is the success rate, that means stone-free rate, and the morbidities associated with that particular procedure, be it ESWL, PCNL, or flexible uteroscopy. So there has to be fine balance between SFR and the morbidities. Otherwise, that procedure will not be popular among patients and among surgeons. We can see the trends of management of stone disease currently. It's the data from US, and there has been significant rise in number of flexible uteroscopy that is being done after 2000, and the number of PCNL and ESWL has decreased. The number of ESWL has decreased, but the number of PCNL has remained static over last 2 decades. Same picture from Germany, and I'm sure that the picture is no different in this part of the world, because in my department, the number of percutaneous surgeries has decreased by around 63% in last couple of years after we started doing flexible uteroscopy. So let's talk about open surgery for a moment. What's wrong with open surgery? Open surgery is a beautiful surgery because it has a highest or high stone-free rate. But still we don't do open surgeries these days. Why? Why? Because of the morbidities that is associated with open surgery. The scar, the post-operative pain, hospital stay, these all factors make open surgery go out of the scene these days. Same with ESWL, right? With ESWL, although it is a minimal invasive surgery, the ESWL is getting, done less and less these days because of the less stone-free rate. So as we've mentioned, the balance between morbidity and stone-free rate has to be very fine. Otherwise, the surgical treatment will vanish. So I just did a PubMed search last night. If you search PCNL in lower pole stone, the trend is decreasing. You know, the publication of trends for PCNL in lower pole stone is decreasing. In 2023, there were only 8 PubMed articles I could find, whereas if you search RIRS in lower pole stone, there were 22 of the recent publications. So that shows not only the number of publications, that shows that more and more procedures of flexible uteroscopies are done for lower pole stones. That's why the people are publishing their work. So in my department, I take lower pole stones and flexible uteroscopy very seriously. That's why we have contributed in lower pole stone management with few articles, and recently we have published a review regarding flexible uteroscopy in lower pole stone. Is it still a challenge? No, not anymore. Similarly, we had a paper in Journal of Endourology whether we should relocate the stone or do in situ dusting for better stone-free rate. So there has been debates in social media as well. There is a very pertinent question. Still, we want to do mini PCNL for all the lower pole stone when it is accessible. You know, newer accessories, newer scopes, newer lasers, all these contributes in the trend in management of lower pole stones. One of the very striking features of flexible uteroscopy is you can relocate the stone and keep it in middle pole or upper pole. There is no more lower pole stone, you know. That's the very unique features of flexible uteroscopy. There is no question of lower pole stone anymore if you relocate it and keep it in upper or middle pole. So we are not treating lower pole stone anymore. So all those so-called difficult features of lower pole will go away if you relocate and do it with flexible uteroscopy, which is not possible in ESWL and PCNL unless you are doing ECIRS. Again, it involves flexible uteroscopy. So earlier, like a decade back, when we think of doing flexible uteroscopy for lower pole stone, we think of 2 factors. It will be difficult to access, one, and the stone-free rate may not be as high as other location. And third factor that we think of is scope damage, right? So it is no more there in 2024, and we'll be discussing those factors. So we have different scopes in our hand these days, right? When we started flexible uteroscopy, we were so afraid of breaking our scopes that we used to pre-stent all our patients routinely, fearing that our scope will get damaged. But the picture is different, totally different. We have lots of scopes, meaning we have, to be specific, we have disposables or so-called limited use scopes so that we can use them in difficult location or difficult anatomy, like lower pole stones, horseshoe kidney, calyceal diverticulum stone, or even we can hand it over to our trainee urologists so that they can learn flexible uteroscopy. So introduction of disposable scopes are very key in management of lower pole stones. I'm sure that organizer of this meeting has not kept this picture in the Congress book without any, they have definitely kept this picture just to highlight the easy manipulations of the flexible scopes into the lower pole, like these cranes, you know. Our scopes these days, can you play this video? So the scopes these days have a deflection of 275 degrees up and down. So that's why it is good to access all the poles of the kidney, including lower poles. Very interesting study from Legemet in 2019 that to access the lower pole, we need to have at least of 215-degree deflection of the scopes. Since our modern scopes have deflection of more than 270 and 275 degree in both ways, accessing lower pole is not a problem at all. Again, my videos are not playing. Can you play the videos? Because when I checked, it was playing. So this is a very famous endocast, from Sampaio. The lower pole's anatomy are not the same. You know, there may be difficult lower pole anatomy. Can I play it from here? So there may be difficult lower pole anatomy calyces, but the end-tip deflections of majority of modern scopes are so good that you can reach very difficult lower pole calyces without any difficulty. The end-tip deflection, sorry because I couldn't play the video, but the end-tip deflection of the scopes are really beautiful, and it works wonderful when accessing lower pole calyces. Again, this video is showing end-tip deflection. The end-tip deflections of different scopes are different, but it is said that fiber optic scopes are better for navigating lower poles, especially difficult ones. One should learn about manipulation of flexible uteroscopy. There are various kinds of deflection that surgeons should learn. Active deflection by deflecting the lever with your thumb. You can also have passive deflection, that is done passively by pushing your scope against the wall of pelvic calyceal system and reach difficult lower pole, deep calyces with acute infundibulopelvic angle. The development of laser doesn't affect management of lower pole stone. No, it also affects management of lower pole stone, because the way we do lithotripsy, the quality of dust we make matters in terms of stone-free rate and also duration of surgery and associated morbidities of flexible uteroscopy. So, development of lasers also contribute in the management of lower pole stone. Thulium fiber laser, recently pulse thulium laser, pulse thulium YAG laser are introduced and are being widely used for the management of renal stones. So we published an in vitro study in management of laser lithotripsy, which was published recently, and it shows excellent lithotripsy efficiency with pulse thulium YAG laser. Newer lasers, namely thulium fiber laser, is showing very promising results, and recently there are comparative studies between holmium YAG laser and TFL about stone-free rate and other factors comparing holmium YAG laser. So what is the good part of having thulium fiber laser when we are dealing with lower pole stone? We can do better dust. In lab studies, it has shown that the dust that is created by TFL is way superior, way finer than holmium YAG laser. We can make procedure faster. More importantly, we have thinner fiber with thulium fiber laser. We can go as thin as 150 microns, which will help us to preserve the deflection of our flexible scopes, to maintain the clear vision by not occupying our working channel much. And since the dusts are better, we are able to suction them and make a complete clearance at the end of the procedure. So this is one very first prospective RCT that was published in European Urology, comparing result of holmium YAG laser and TFL, and they have done lower pole stone as well, and it has shown good result for lower pole stones. So when we have better laser, when you do good laser lithotripsy, the quality of dust that we get at the end is quite fine, you know, you don't have to worry about stone-free rate. Those fine dust will flush away at the very next act of bicturation. At the end of the day, if you do CT scan with this quality of dust, then you will have good stone-free rate. So better understanding of laser is very essential in management of lower pole stone. So you still want to do PCNL in this era to increase the pain, post-operative pain, keeping longer duration in the hospital, patients in the hospital. The post-operative stay, you have to keep the patient in the post-operative ward, probably transfusion rate, because in flexible uteroscopy, we never transfuse, we don't arrange the blood, and possible need of angioembolization even in a very few patients, you know. These factors have been proven by multiple meta-analysis and systemic review. Can you play this video? So recently, suction RIRS has been introduced, and it has been said that it is a game changer. You know, you can suck all the stones, not only stone dust. You know, you can even suck the stone fragment with blendable access sheath. There are navigable blendable access sheath that can go into the lower pole. Since the video is not playing, I'll show. This is the access sheath that is going in the lower pole, and you can do suction of all the stone fragments that you have broken. And the CT scan was done on the very first day of the procedure, and it shows 100% clearance. So if you want to compare PCNL or mini PCNL with RIRS, now you have to compare PCNL with suction RIRS. Then you will get the new result. You know, you can't compare apple with oranges. Now, if you want to do a good comparative study comparing results of flexible uteroscopy and mini PCNL, we have to do with suction RIRS. So on the lighter note, stabbing at the back for lower pole stone removal is not acceptable in 2024. So to conclude, RIRS is ever evolving. Lower pole stone is not an exclusion. RIRS should be the procedure of choice to treat the lower pole stone in 2024. Stone location only, stone location only. I don't mention stone volume. Yes, for larger stone, there is a place for mini PCNL or PCNL, but stone location only should not be the determining factor in the stone management. Thank you.
Okay, congratulations. And to start the debate, Dr. Shesthra, and to argue back and support the case of PCNL, we have our own Dr. Balagobi Balasingham. Dr. Balagobi doesn't need any introduction, but to complete the formalities, he is a senior lecturer attached to the Jaffna Teaching Hospital, and also a consultant urologist attached to the same teaching hospital. And something special about him is he is the first to get the FRCS urology intercollegiate exam in our urological fraternity. So that is one plus for him. And Balagobi, over to you to counteract Dr. Shesthra's arguments.
Thank you, sir, and good afternoon. Thank you very much, my colleague Dr. Anil, for the wonderful scientific input. So now you will have to believe whatever I say, because there's no rebuttal after this. So lower pole stone is the commonest renal stone because of the location. So 1/3 of the renal calculi are located in the lower calyx. And inferior calyx pose a lot of difficulty considering the access and regards to eliminating the stone fragments. For last 10 years, this debate is going on between the PCNL and RIRS. Unfortunately, there are no large prospective randomized studies to compare these two, but there are small scale studies and meta-analysis and systemic reviews are there. So when come to the lower pole stone, what are the options we have? Of course, PCNL, ESWL, RIRS, combined approach, and sometimes deferred management. I think today's talk, it's just comparing these two. But we have to remember, the stone size also is important when comparing these two options, whether they are less than 1 centimeter or whether 1 to 2 centimeter or is more than 2 centimeter even with the partial stack horn. Selecting which one, it's a difficult choice. So I will give the evidence behind why I am proposing the PCNL. Of course, if you take the PCNL, the stone free rate is location independent, whether it's in an upper pole or it's a pelvis or it's a lower pole. So we are not considering the location of the stone when we are talking about the SFR. And Dr. Anil was talking about the technological advancement in the FlexiURS, but the same improvements of technology is happening with the PCNL. Regards to the size of the track and the energy devices and other accessories. And he was talking about the complications. Of course, I agree. But with the smaller sizes of the track, and the lower pole access is relatively easy when compared to the upper pole because of the location is most of the time is below the 12th trip. So this is a randomized control trial comparing the lower pole stones with the mini PCNL and RIRS. And they say far is far better with mini PCNL. Because we are seeing the stones, we are removing the stone, we are removing even the dust. So we are talking about Rundle's plaque in the stone formation. So the tiny Rundle's plaque ultimately give rise to the stack horn. So I think even the dust is a matter. But if you take the PCNL, the SFR, again, it's not depend on the size of the stone up to 3 centimeter. We know that our conventional studies, lower pole 1 and lower pole 2 studies, when you compare those two, the stone free rate is better in PCNL than FlexiURS, and FlexiURS have a better stone free rate when compared to the ESWL. A prospective randomized trial is comparing the complications. Of course, I agree with you, the complications are more with the PCNL. But the problem with these studies are, most of these studies comparing the complications of the standard PCNL with the FlexiURS. You all agree with me, the mini PCNL have a lesser hospital stay and lesser bleeding. And why we are worried about tiny fragments, residual fragments in the lower calyx? These studies indicate that 43% of the patient with the residual fragment less than 4 millimeter had a symptomatic episode or another additional intervention within 2 years. So even a small fragments of residual stone, it's important. Another meta-analysis comparing the clinical efficacy of the PCNL with FlexiURS. And you can see the SFR is far better with the PCNL. Now, Dr. Anil was talking about the anatomy of the lower calyx is not much important in newer scopes. But if the infundibulum pelvic angle is more acute, or if there's an infundibulum width is less than 5 millimeter, of course, it's going to be an issue in reaching the stone. Even relocating the stone is going to be difficult. Suppose you see the stone like this, relocating or removing the dust, even with the flexible sheath, is going to be an issue. Now, there are multiple studies that indicate the impact of renal anatomy decide the stone clearance in the lower pole stones when we are using the flexi-URS. Now, the Gresco and teams was saying that 7% of the time they couldn't reach the lower pole stone. Maybe in 2024, this number may be less, but we will still have a number, maybe 5% or 3%, where we can't even reach the lower pole with the flexi-URS. And how many times the ureter is not accommodating the sheath or flexi-URS, so then we had to put a stent and come out. And when there is a stone residual fragments, then we have to do another procedure. So we have to think these outcomes. And most of the companies talking about or marketing about the scopes, but they never talk about the bends of the scope after putting the instruments like baskets and the laser fibers. Of course, after putting the baskets and the laser fibers, the amount of deflection we get is very less. And as you said, of course, I understand there's a dramatical improvement in the technology. Same thing is happening with the PCNL. Especially after the supine PCNL, the outcomes are far better. Now, we have a motto, the regional problem and regional solution. Now, if you see the availability of the scopes, flexible URS scopes in Sri Lanka, the marked in the blue is the government sector, the red is the private sector. So, because of the economic crisis in the country, for the last 3-4 years, we couldn't buy any new instruments to the hospital. With this maldistribution in our country, how we can just rely on the flexi-URS. The other issue is how we are going to train our juniors to do this. Of course, 2024, things can change. And Dr. Anil was saying, now the cost of the scopes are less, is widely available in India. So with the time, if we get more scopes, yes. And the costs. But I have seen in most of the studies, they are saying the cost in the PCNL is more. Then if you go in a detail, they say the hospital stay with the PCNL is average is 3.5 days. The flexi-URS is 1 day. But you all will agree with the mini PCNL, the hospital stay is usually 24 hours, admit the previous day and discharge next day. So if you remove that hospital stay expenditure, If you just consider only the scope and theatre expenditure, definitely the PCNL, mini PCNL will be a better choice. Because in Flexi URS, you have to buy baskets, laser fibers, access sheath, and we have to think about the scope damage. And we know that the reusable scopes, on average, we can use only for 20 to 40 cases. Then Dr. Anil was saying about single-use scope. Yes, that's good. But what about throwing the instruments in the environment after the single use? We are talking about the green energy. Are we going to make more e-pollution? So that's my question to Dr. Anil. And this, the picture I have taken from Dr. Anil's presentation. So regarding the intrarenal pressure, of course in the PCNL, especially the supine PCNL, it drained by gravity, and we have a space between the access sheath and the scope, minimum about 2 French. But when you put a 10 French, 8 French access sheath with 7 French scope, and when you are breaking a 2 centimeter stone, the intrarenal pressure is going to rise a lot, and we are going to have the pylovenous and pylolymphatic bacterial translocation. But that's not the case with PCNL. And what about the ureteric damage with the access sheath and the Flexi URS? So we are not doing any harm to the ureter during the mini PCNL. So there is a pure trial, a multi-center randomized control trial is going on in UK. This will give the more updated answer for our questions. What's the guideline says? The EAU, more than 20 millimeter, first choice is PCNL. 10 to 20 millimeter, they recommend endourology if the lower calice is favorable. And less than 10 millimeter, all the options are available, including the deferred management. AUA, same. So larger stone, more than 2 centimeter stone, definitely PCNL. But between 1 to 2 centimeter, which direction we are going to move? It's a question. And we have to understand these two instruments are complementary, so we can combine and use in difficult cases. In conclusion, stone-free rate is better with PCNL, especially in the larger stones. Complications are more with PCNL than Flexi URS, but with advancing technology, reducing in size of the sheath is going to be less and less, and with the experience of the operating surgeon, it will be less. Flexi URS, the cost is a problem, especially in a country like Sri Lanka, and the lower pole anatomy still can limit the access. So choice depends on the surgeon, stone, size and the density, the anatomy, and the patient preference, and the cost factor. So we need a more larger prospective randomized trials. Thank you.
In the interest of time, I think we might not be able to go into lengthy discussions, but Dr. Shesthra, do you have anything as a rebuttal or any comments on Dr. Balagobi's presentation. A short comment.
Regarding scope damage and economy of lower pole management, I know there will be variation among countries and economical status, but the way we do flexible uteroscopy 10 years back and now has changed dramatically in developing countries like ours as well. I'm sure my friends from India, friends who are doing flexible uteroscopy even in Sri Lanka, Bangladesh would agree to me, not mentioning developed countries like UK, US, and European countries. So the economy is changing. You can't compare cost analysis of UK and America in our context. It doesn't match. So yes, I would agree that cost analysis should be done in our setup. And introduction of single-use scope is not single-use. The very good scopes from India, endoscope, is unlimited hours use and has excellent vision and maneuverability. We don't have to depend on Western scopes anymore. You don't have to send your scopes for months for repair to Germany anymore. So the way we do flexible uteroscopy has changed. I wouldn't say for the last 10 years. It has changed even in COVID, post-COVID era. So I would suggest considering flexible uteroscopy even for lower pole stone. Yes, there is a definite and strong place for mini PCNL or PCNL in management of large stone. But isolated large stone in lower pole is not very common. In lower pole stone, the stones are not very big. I wouldn't say it is bigger than, you wouldn't see isolated lower pole stone bigger than 2 or 3 centimeter. So most of the lower pole stone can be managed with flexible uteroscopy. One, regarding lower pole anatomy, the studies that Mr. Balagobi has, Dr. Balagobi has shown that the measurement of lower pole anatomy with preoperative images is very tricky. It's not always represent intraoperative lower pole anatomy. So the amount of contrast injected by your radiologist, the amount of hydration status of the patient, and the images taken, that all difference, because we need a good analysis or good study in terms of measuring lower pole anatomy. And most of the lower pole anatomy studies came from ESWL era. You can't replicate those results of lower pole anatomy in this era, in 2023. So lower pole anatomy, especially with preoperative images, are not very representative of intraoperative pictures. So that's why our scopes are getting slimmer. The slimmest scope that we have in clinical use is around 7.5 FR now. I was told that some company is launching even a slimmer scope of 6.9 FR very soon. So when the scope's getting smaller, the access to lower pole and other calyces are better. One, chances of ureteric injuries will be much less because you don't have to use bulky access sheath. You can go sheathless, you can go smaller access sheath. So introduction of smaller smaller flexible scopes are very key. Thank you.
Thank you, Dr. Shesthra. In the interest of time, I think we'll conclude this session.